presentation is from Alessandra Di Giovanni, came from Italy, from Avellino. It's a gynecology of kingdoms of sonography, of ultrasound. And the presentation is about infertility and fibroids, correct ultrasound diagnosis for proper treatment choice. Please.
Thank you. Thank you for your kind introduction. Let me thank once again Attilio, Sergio, Luis, and all the organizing and scientific committee for this invitation. It's a real pleasure for me to be here with you today. So, I'm particularly proud to introduce you also. It's my first official commitment with the new name of our institution, that it's going to be since a few days the Balzoni Research Hospital. I'm a sonographer and I'm completely focused on gynecologic ultrasound. So let's go together through what we can do by sonography to provide the surgeons all that clinical information that can be relevant for clinical and surgical strategy of management of the patients. We cannot speak, of course, about fibroids without referring to the consensus paper, the MUSA paper, that provided us terms, definition, and measurements to describe all that sonographic features of myometrial disease. What we should observe when we face a myoma. First of all, morphology. By sonography, we can observe the shape that is usually rounded, ovular, lobulated. We usually observe regular contours, well-defined contours. The typical heterogeneity with usually many shadows that we can observe in this kind of lesion, and of course also the vascularity that usually in typical fibroids is really poor, limited to the peripheral capsule, and we will see together how more vascularized myoma can be defined as atypical. Just to remind you that vascularization can be classified in 4 points according to the score that range from 1, that means absence of vascularity, as it happens for adnexal masses. 2, when vascularity is really poor and limited to the peripheral area of the myomas. We have score 3 or 4 when vascularity is higher, and we also can observe vessels in the inner part of the lesion. Concerning position, we should always refer to the FIGO classification of myomas. So we have 8 points according to the location of the lesion into the uterus, with the 8 that is not displayed because it refers to myomas that are that have a typical position that is outer of the corpus of the fundus, such as for cervical myomas or parasitic myomas. When we speak about the relationship between myomas and infertility, the concept is really easy and intuitive. So the closer the myoma is to the endometrial cavity, the higher is the likelihood of an impact, of a detrimental impact of a reproductive outcome of the patient. And we have several different mechanisms by which it happens. First of all, the mechanical distortion of the uterine cavity, the deformation of the uterus, cervical displacement that can impair the sperm passage, an alteration of myometrial contractility, blood supply, deviation or an impact on tubal ostia, but also molecular mechanism concerning, for example, chronic endometrial inflammation due to the presence of myoma and subsequent histologic alteration. We know also that the presence of fibroids, also intramural fibroids, not only submucosal fibroids, can have an impact on myometrial peristalsis. So it seems that the higher is the frequency of myometrial peristalsis, the higher will be the probability of a detrimental impact on pregnancy rate. And also we know from literature that we have some mechanism in terms of impairment of inflammation mediators that can act as paracrine interaction and that can affect the entire endometrium and not only the area that is in contact with fibroids. So considering all those mechanisms, we should take a decision in terms of treatment, to treat or not to treat those lesions in patients that complain with infertility and reproductive troubles. I won't go through indication to treatment because we will have a lecture after on this issue, but I just want to highlight what we can do by ultrasound in order to provide all that information that can be relevant for this decision. I'm really grateful and thankful to the colleagues of Thessaloniki University who made the most of the job in this nice paper, who compared all the guidelines that today we have about the relationship of fibroids and infertility. We have these 5 guidelines that just to resume, almost agree about the concept of treating all that myomas that have an impact of endometrial cavity. Some of these guidelines define in terms of diameters, give some cutoffs in order to decide what kind of myoma should be treated or not. Some of these guidelines emphasize which should be the diagnostic methods in terms of ultrasound or MRI in order to achieve a correct diagnosis. So, let's go through what we can do by ultrasound. Of course, we can observe the morphology, as we told, the vascularity, but we should measure this lesion. We should identify the location in the uterus. When we have submucosal fibroid, we can give information about the extension of the base, the degree, if present, of intramural development, and information about the myometrial free margin in order to perform a safe surgery. So let's observe together some example. This is a typical fibroid, intramural submucous of 2 centimeters. It's an easy case. You can observe the regular contours we mentioned before, the poor vascularity that is mainly at the periphery of the fibroid. So no doubt about the fact that it's a typical fibroid. And of course, the 3D coronal section help us to evaluate better which is the impact of the fibroid on the uterine cavity. So here you can see how this fibroid impact on the right margin of the cavity. This was a patient wishing to conceive, so of course we decided to treat. In those cases, we should measure the minimum distance, not only the fibroids, and visualize the impact, the deformation of the cavity, but also, as we told before, we should measure the minimum distance between the serosal surface of the uterus and the outermost border of the lesion. This is another case in which we have a similar fibroids. It's a little bit larger, 3 centimeters and a half. In this case, you see from the 2D view that it seems to have an impact of endometrial layer. Here, we can have a depth between number 2 or 3 because you see the border of the fibroids, it's really close to the endometrial cavity. It doesn't seem to impact it so much. So in this case, we also could give a number 3 classification according to figure classification. But you can see how 2D coronal section can help us in order to better see the relationship between the lesion and the cavity. In this case, you see the right tubal angle was completely compressed by the lesion. So in this case, with this fibroid that impacts the cavity, has main intramural development and also some degree of subserosal development, we should give a 2-5 classification according to the FIGO staging. Another case in which we can have some doubt between the 2 and 3 degree of development of the myoma. You see this 3 centimeters fibroid, it's intramural. For sure, it's completely in contact with the endometrial cavity. We can measure the myometrial free margin in this case. And again, the 3D coronal section help us to see that actually it has an impact on the cavity that it was not so clear from 2D section. So just to emphasize you how the addition of 3D volume reconstruction of the uterus can help us to achieve a better diagnosis. This is another case in which the impact on uterine cavity is clear since the 2D evaluation. Here we have the typical fibroid. In this case, it's a fundal lesion. From here, we can see how deformed is the endometrial layer in the third upper part of the cavity. The diameter of the lesion is, the maximum diameter of the lesion you can see is 3 centimeters and a half. No doubt about the fact that endometrial cavity is deformed in its upper third, but of course in this case we have another reason to remove this lesion, that is this high vascularization. It was a rapidly growing myomas. Here we can give for sure a color score between 3 and 4. You see vascularity is really rich, and not only in the peripheral part of the lesion, but at the 3D volume reconstruction of power Doppler, we can see how vascularity is represented also in the inner part of the lesion. So this is another issue that we have to take into account, because we know from literature, this is a work that we published 2 years ago, in which we observed 70 fibroids, high vascularized fibroids, and we analyzed the histological reports, and we found that among myomas with a color score between 3 and 4, we can expect up to 80% of malignancy, of course, in patients usually aging more than 40 years. I mean, the majority of them are still benign. In 44% of cases, they are leiomyomas variants, so the so-called atypical leiomyomas, and in 60% of cases, they can be adenomyomas. Because we should also take into account that we can also have the concomitant presence of fibroids and adenomyosis. In this case, the patient was referred to us for infertility, and she complained also abnormal uterine bleeding. Of course, but she was diagnosed just with fibroids. When we observed the patients, for sure we found that this is a typical small centimetric lesion, that was a typical fibroids. You see how regular are the contours, poor vascularization, but this other lesion, it doesn't resemble a myoma. You can see we cannot recognize the typical capsule that we expect in a typical fibroids. And vascularization is very poor also in these cases, so it doesn't help so much. Both the lesions for sure had an impact of endometrial layer. You see how distorted is here in the right side, but one was a fibroid, the other one was an adenomyoma. So we should always able to distinguish between fibroids and adenomyosis in terms of morphological features, because it's of utmost importance for clinical management of our patients. We know that in adenomyotic lesion, even focal one, margins are not so defined, and also the vascularity usually is not so limited to the peripheral area of the lesion. We can also have vessels that can be perpendicular to the borders of the lesion itself. And so this is the case that I showed you before. You can observe here how irregular was also the junctional zone at the 3D reconstruction of the uterine cavity. And in fact, this patient has had also diffuse adenomyosis. She had attached tubes, and she has some small deep infiltrating nodules at the level of the retrocervical area. So probably in this case, the presence of small fibroids impacting the uterine cavity was not the only reason for her reproductive impairment. What we should always take into account is that we should not stop to the first trouble that we face with. This is another case in which we have a 4 centimeters fibroid. The case is really similar to that I showed you before. So a fundal myoma that is for sure impact of endometrial layer. But let's observe the rest of the myometrium. Here you can see some typical stripes that are common in common features, specific features of diffuse adenomyosis. And in fact, here you can see the fibroids that displace the uterine cavity, but also we can notice how irregular is the junctional zone of these patients compared with the case that I showed you before, in which the junctional zone was really perfect. And also in this case, the patient was affected by extensive endometriosis with the typical kissing ovaries, with both ovaries attached between them and to the uterus, and endometriomas on both sides.
Please, can you conclude?
Yes. This is my first slide, this is my last slide, I'm sorry. So what I want to emphasize is that the first question we should answer when we approach a patient affected by myometrial disease is if it's a myoma and if we have just myomas. So I think that the main advantage of ultrasonography and as well as MRI is the possibility to perform a complete evaluation of pelvic and abdominal disease of the patient in order to have a clear idea of which factors can impact infertility. And then when we identify the presence of fibroids, we can provide all that information that we need in order to set a proper surgical strategy. So the advice is look always at the big picture. So let me to invite all of you from the ultrasound kingdom and also, of course, hysteroscopy and surgeon to our next upcoming event in next May in Salerno. We are very excited about this event that last year was held in this location, but now we decided to move closer to home. So for all of you that can be interested, we wait you there. Thank you so much for your attention.